Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Jody Rich, Brown University School of Medicine and Epidemiology.
My name is Dr. Jody Rich. I'm a professor of medicine and epidemiology at Brown University and attending physician at the Miriam and Rhode Island hospitals, and I'm also a consultant at the Rhode Island Department of Corrections, a job I've had for the last 25 years.
How would you advocate for MOUD programs in corrections to government officials?
When I talk to patients who have this disease, who are involved in the criminal justice system, invariably I find out that the reason they're there is ultimately because of this disease. And so fortunately we have effective treatments for this disease. They're not perfect. There are other diseases that we have better treatments for. There's other diseases we don't have nearly as effective treatments for. So the treatment is highly effective, and we have, for the last 40 years, essentially failed to take advantage of that opportunity. The opportunity being to actually diagnose people with this disease, start them on treatment, and continue them to treatment on the outside. If we were to do that nationwide, we would take a significant chunk out of this epidemic and go a long ways towards addressing this problem. So that's it in a nutshell. Now, to get there, we need politicians, we need policymakers, we need the general public to understand the disease of opioid use disorder or opiate addiction. We need them to understand that these treatments are the best thing we have, and that they are effective. Not for every person, not every time, but they are the best thing we have. So really the challenge is to pass on that knowledge. And it's more than knowledge, it's a whole culture change. You know, when we think in this country about someone who is a drug addict, we think that person is a criminal. That's what we've done with our culture. And in fact, this is somebody with a disease. So if we thought of a diabetic as a criminal, well, that person is using too much glucose. He's eating too much sugar. He needs to, stop that, and we need to get him to stop that. Well, that's true. But we don't decide to use the criminal justice system to do that. So in a nutshell, we really need to change the culture in our society and in our policymakers, in our politicians, and in the departments of correction to recognize that this is a treatable disease and that we're going to have far better outcomes by treating it as a disease than punishing it.
How does Rhode Island's MOUD in corrections compare with the rest of the country?
I've been working at the Rhode Island Department of Corrections for 25 years, and I went in to take care of people with HIV because we had another deadly epidemic that was killing young people in large numbers. And at the time I went in, we did not have effective treatment. And then we developed effective treatment. And we had a very aggressive screening. We diagnosed people. We got them started on treatment as soon as it was available. And then we linked them up to treatment on the outside. And we developed a model programs. We got funding for it. We wrote about it. It worked fine. And that was a success story. And but then being out there every week at the Department of Corrections, realized, wow, Most people here don't have HIV, but most people have illness, and in fact, you look at almost any disease, this is a population that has a higher prevalence and more advanced stages of disease. So this is a population that's impoverished, disadvantaged, stigmatized, more minority status, and low health literacy and low literacy, low rates of medical coverage and medical access. So you can look at almost any disease and realize this is an important population to intervene upon. But addiction is what the majority of people have. Less than 1% of people have HIV in our correctional facility, but more than half have some addictive disorder, whether it's alcohol or illicit drugs. And most, in general, those are what landed people to get involved with the criminal justice system. So we started thinking, well, why not, do the same thing we did with HIV: screen the population, diagnose the population with disease, and start treatment and link them to treatment on the outside. Well, there is a lot of stigma around HIV. There's a lot of stigma around homosexuality. There's a lot of stigma around being incarcerated. But the stigma around addiction seems to me to be far more powerful and prevalent. And so running in to try and run with that as an idea felt like running into a brick wall. Oh no, we don't do that. It doesn't work here. Well, the medicines work on the outside. Sorry, it doesn't work here. So then we set about trying to develop the evidence base. So we wrote grants and we did studies and close collaboration with the Rhode Island Department of Correction. We would, and then we got clotheslined again and we knew there would be some culture change with the correctional officers, but it was the nursing and medical staff that came out of nowhere. And we said, well, why are you so opposed to getting people started? Well, at the time, methadone was what we had. And the policy was that people would get taken off of methadone. They would get tapered off in Rhode Island. In neighboring Massachusetts and many other places, people coming in on methadone get no taper, which to my mind is inhumane, is cruel, is torture, and should not happen. But the nurses would give the people gradually decreasing doses, and of course they're going through withdrawal. It wasn't as bad as if they stopped all of a sudden, but it was miserable. So they would see the patients every day, giving them their dose, and getting sicker, and just feeling miserable for, it takes a month or two to get through that. And then they would feel better. They would feel they had gotten the other side of the detox. And so the nurses felt like they had accomplished something. And so they said, well, why would you want to put them back on? We just went through all this pain and misery to get them off of this medicine. Why would you want to start it again? Why would you want to retox them after we've detoxed them? So to get them to understand why that's important, I had to actually take the nurse to the bedside, to the patient, and I would interview the patient. Mr. Jones, how many times have you been incarcerated? 5 times. How many of those 5 times has been related to your using illicit opiates? Oh, every time. When you've gotten out before, have you started using heroin, illicit opiates again? Yes. How many of those times? Every time. How long did it take you to start using again? Well, one time it was waiting for me in the parking lot when I got out. Another time I went for a week. Another time I went for a couple of weeks. One time I got onto methadone, I went for 3 months. And then my insurance ran out and the methadone stopped and then I was back. So you're telling me the only time since you've had this disease for all these years that you haven't been using has either been you've been here under lock and key or you've been that 3 months you were on methadone. Yeah. Now you're getting out next week. Are you planning to relapse to heroin? No. And you're off of methadone right now? Yes. Do you want to relapse to using drugs? No. Are you going to relapse? Yes. Why do you say that? Because I have no control over this disease. If I'm there, I will relapse. And the data confirms this. If you put people through detox, 90% will relapse. So it's not a matter of methadone being good or bad versus just being on nothing. These people, it's almost like telling a diabetic, like, okay, well, just, get out there and don't have your sugars be elevated. It doesn't work. You need the insulin. For many patients, they need the methadone. They certainly need it at the time they get out because their risk of relapse is sky high and their tolerance is 0. So they are at extreme risk for overdose and fatal overdose. So after going through that conversation with the nurse, then the nurse would say, okay, now I get it. It's better to be on methadone and have control of your life than to not have control, overdose, and be on risk for dying.
How was Rhode Island able to get the support to implement MOUD in corrections?
The story of how we got to where we got to was, we built up the evidence. We published papers in top journals. It turns out the same medicines that work in people in the community who have this disease also work when people are incarcerated and transitioning out. But there was still a long way to go to make this policy happen. And I would say the first bit of credit goes to our governor, Gina Raimondo. She is interested in an evidence-based approach. She set up a task force, made this an expert-driven task force. She got all the stakeholders together and give them 90 days to come up with a statewide plan. So a typical stakeholder-driven process, people are all stakeholders. So they will say, hey, I have a good idea. Why don't we fund my program and that will be our plan? And everybody else around the room says the same thing, and you come up with, 87 different plans and none of them get enacted. So this was an expert-driven process. So the governor appointed experts to be involved. I was fortunate enough to be one of those experts. And we did a very intensive 90 days of interviewing 100 different key stakeholders and did public forums and a lot of outreach. And we came up with a 4-point plan for the state, a strategic plan, not a comprehensive plan. And one of those points, in my mind, the cornerstone was treatment. And we basically said Rhode Island has a population of 1 million. There's about 20,000 people with this disease who would benefit from being on these medications. So we need to expand the capacity and we need to identify those people and encourage them to get onto treatment. So where do we identify them? Well, they all come into the medical system, so in the hospitals and the emergency rooms and the clinics and drug treatment programs. But they also come into the criminal justice system. So police, courts, jail, prison, probation, parole. And each of those is a touch point, an opportunity to to identify someone with this disease, educate them, and get them started on treatment. And so we suggested, the governor came back to us, said, that's a great plan. Where do you propose that we invest resources? And we said, in the Department of Corrections. She said, why would you say that? Well, because these are the people most advanced in their disease. They're taking the greatest risks. And because when they get incarcerated, they get taken off their medicines, they lose their tolerance, they're at increased risk for relapse and overdose on the way out. And if you want to stop deaths as quickly as possible, that's where we need to invest right away. The governor heard that advice, allocated $2 million to start this program. The General Assembly agreed, and the program is off and running. Now, Dr. Jennifer Clark is the medical director. She is a force of nature. And she said, this is the population that I'm in charge of their health. This is the number one thing that's killing them. And I'm not going to just continue methadone on the few lucky enough to come in on methadone and I'm not going to sprinkle a little Vivitrol on a few coming out the door. I'm going to screen for this disease, and anyone who has this disease, I'm going to tailor the best treatment possible for each of those individuals and make sure that they have every chance to get into treatment on the other side. And that's really what led to a dramatic drop in overdose deaths.
What challenges do individuals face upon reentry to their community?
If you started people on medications on the inside and you didn't connect them to treatment on the outside, or let's say you connected them to treatment but they don't have insurance, or they don't have transportation, or their family is telling them, oh, you don't need that stuff, and then they get off it. I can't tell you how many patients I see at the Department of Corrections show up and I ask them what happened. Well, they say, well, I got onto methadone, or I got onto buprenorphine, Suboxone, and I was doing well. And then my family told me, or my wife told me, oh, get off that. You don't need that anymore. And so I stopped taking it. I tapered off. And then I don't know what happened. I just relapsed, and here I am. I lost my wife. I lost my kids. I lost my job. I lost my car. I lost my housing. And I don't know what to do. So that is a broken record player. So we really have to educate the public about the importance of this and maintain treatment into the community.
What factors contributed to the profound success of implementing this program?
I think it took a lot of courage for the governor and the politicians to step up. It took leadership on many levels. The administration at the Department of Corrections did not hesitate. The leadership of Dr. Clark was extraordinary. The leadership of the governor was extraordinary. So I think in that sense, yes. And the fact that the epidemic in Rhode Island has reached that point where so many people are impacted, that we knew something had to happen. And the fact that we had all the stakeholders in the room with the governor's task force. So I think we had some advantages, but I don't think this means that this can only be done in Rhode Island. I think this can be done everywhere and should be done everywhere. And so I think, the fundamental question is, do we think, there's several of them, but do we think that people who are incarcerated should not get treated for the underlying disease that caused them to get incarcerated and be at risk for dying after they get out?
What changes occur in correctional settings with the implementation of MOUD?
In New Mexico, there's a jail where they've had methadone for over 10 years. And a new sheriff came in and said, we're the methadone for prisoners, we're gonna shut that down. And there was a public outcry. No, you can't do that. And leading the charge were the correctional officers. And they said, you can't shut that down, because they'd seen what happened before when people came in and were in withdrawal and basically corrupting the jail to try and get drugs. Whereas you put them on methadone, they're fine. I would much rather run a jail with people who needed methadone on methadone than people without it. It's far safer for everybody involved. It's the right thing to do. You put people on, you take people off of opiates, and many of them are going to be scheming and trying to corrupt the system to get what they want, what their brain is telling them they need. And you put them on methadone and they're fine. They're normal, reasonable, rational people. And, for pennies a day worth of methadone, they're fine. And that, of course, begs the question of, do they actually need to be incarcerated? But they didn't want to go back to that, contentious situation, and I don't blame them. So, I think it's going to take a while, and we've seen that in the Rhode Island Department of Corrections. Initially, a lot of resistance, and then gradually, as people realize how well it's working, they come to support the system.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.